Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 3 of this 3-part CMEOCast podcast series titled Maintenance Therapy in Metastatic Urothelial Carcinoma, Integrating Current Treatment Options into Practice. This podcast series is supported by an educational grant from Pfizer Incorporated and EMD Serrano Incorporated. I'm Dr. Daniel Petrolak, Professor of Medicine and Urology at the Yale School of Medicine. I'm also co-director of the Signal Transduction Research Program at the Smilow Cancer Center at Yale Cancer Center in New Haven, Connecticut. I'm joined today by my esteemed colleague, Dr. Guru Sampavdi. Dr. Sampavdi is the Bladder Cancer Director at the Dana-Farber Cancer Center, Associate Professor of Medicine at the Harvard Medical School in Boston, Massachusetts. Welcome, Guru.
Thank you, Dan.
In addition to CME/CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. Over the next 90 days, actively work to incorporate improvements into your practice presented in today's activity. CMEO will send you a follow-up survey in approximately 3 months. Upon completion of the survey, CME Outfitters will send your confirmation to submit to CMS attesting to your completion of the CME for MIPS improvement activity. Our learning objectives for this episode are to evaluate the efficacy and safety data for maintenance and immunotherapy regimens in first-line metastatic urothelial carcinoma and to employ it in its discussions with patients in order to choose the optimal evidence-based course of treatment. So we know that there are multiple factors which influence the treatment landscape in patients who are receiving therapy for metastatic urothelial carcinoma. There's guidelines, there's experience, there's evidence, there's lifestyle, there are preferences by individual patient. Of course, there are side effect concerns as well. Prognosis also comes into play, where the patient has extensive disease or nodal disease or visceral disease. All of these are incorporated into the decision process and how we make a decision as far as our patients are being treated. As treatments evolve, patients and families require timely and up-to-date education about the treatment and possible adverse events prior to the treatment initiation. We need to show patients and their families the options for treatment and to arrive at decisions together. We need to encourage patients to alert all healthcare providers about their treatment and to report any changes to each multidisciplinary provider included in their care. Consistently assess and document adverse events at each visit when the patient comes to be evaluated to enable the clinical team to note changes that may occur over time, and closely monitor over time all adverse events to detect minimal changes that may detect an early adverse event or a particular trend. So we've actually reviewed 35 articles written on shared decision-making in oncology and found 3 consistent themes and barriers to shared decision-making: uncertainty or lack of consensus in the treatment decision, patient concern regarding adverse events, and poor physician communication. So finding balance when sharing treatment data with patients can be sometimes difficult. Guru, as we go through the next few slides about treatment data, I would like you to also share some tips that you may have about your approach to delivering information to the patient as part of the shared decision-making process.
Thank you, Dan. So just to prepare the patients in terms of systemic therapy, the systemic therapy, you think about systemic therapy in terms of first line or second line and beyond. And in the first line setting, we think of patients as being cisplatin eligible or cisplatin ineligible. In cisplatin eligible patients, patients receive the gemcitabine cisplatin chemotherapy for 4 to 6 cycles, followed by switch maintenance avelumab, the PD-L1 inhibitor, the immunotherapy drug, as maintenance therapy. And in cisplatin ineligible patients, we usually give them gemcitabine carboplatin-based chemotherapy, 4 to 6 cycles, followed by switch maintenance avelumab, where it's been shown in a phase 3 trial. In the second line setting, in patients who receive the platinum-based chemotherapy and are on a break, And again, this was more of a convention in the pre-Javelin Bladder 100 era, which looked at the benefit of switch maintenance avelumab. So in that setting, we have PD-1 L1 inhibitors approved for patients with progressive disease post-platinum-based chemotherapy. And this space might be contracting given the advent of the Javelin Bladder 100 era. Now, if a patient has a specific FGFR activating mutation in the FGFR2, FGFR3, mostly 3, there we have erdafitinib, an oral targeted agent that targets all the FGFRs in this space. So erdafitinib is approved in the post-platinum setting with or without prior checkpoint inhibitor exposure. And in patients who don't have an FGFR activating alteration, we also have the antibody drug conjugate enfortumab vedotin approved as third-line treatment, post-platinum-based chemotherapy, and an immune checkpoint inhibitor. Now, of course, we have, with the advent of the Javelin Bladder 100 data, switch maintenance approach. It's important to remember and not to lose sight of the fact that cisplatin-based chemotherapy can cure some patients. So with cisplatin-based chemotherapy, the median survival is 14 to 15 months as first-line treatment. But we know that around 15% of patients, maybe a little less based on some other studies, do have survival up to 5 years. And these might be patients with good performance status and no visceral disease, only lymph node or soft tissue disease. So this has been something we have that's been a debate in the community, whether some patients with cisplatin-based chemotherapy with a complete response could live without switch maintenance, but that is not been teased out, of course. So what are the goals of maintenance therapy? So our standard used to be platinum-based chemotherapy. We get up to 6 cycles was the target, then we give them a break. But the problem was when we gave them a break, many of these patients progress fast, and we know historically that approximately half of all those patients never even received second-line treatment. So maintenance, switch maintenance therapy is a new paradigm in the space with data from Javelin Bladder 100, which showed that switching to avelumab while patients are in the post-platinum space with stable or responded disease, then given avelumab, there was an improvement in outcomes before they progress. So this would ensure, of course, an earlier delivery of a PD-1, a PD-L1 inhibitor in this case, which of course did show an improvement in outcomes in the Javelin Bladder 100 trial, in which of course Dan was involved. So Dan, you want to tell us about the Javelin Bladder 100 trial?
Absolutely, Guru. Thank you. So the Javelin 100 trial was a randomized trial. It was an international study that took patients who received either cisplatin gemcitabine or carboplatin gemcitabine. They had to be responding with a complete or partial response. And they were switched to avelumab chemotherapy after 4 to 6 cycles of standard chemotherapy. So this was a way of giving maintenance therapy after these patients had responding tumors. And patients were treated with avelumab at 10 milligrams per kilogram Q2 weeks for as long as the drug was working or until the patients developed unacceptable toxicity. The primary endpoint was overall survival, and that was both in all randomized patients as well as in the PD-L1 positive patients. And the secondary endpoints were progression-free survival by RECIST as well as objective response rate. And as we see from the first slide of the Javelin study, avelumab will improve survival in all patients who were treated in all treated patients. So not only the PD-L1 positive patients. The median survival for avelumab plus best supportive care was 21.4 months versus 14.3 months for best supportive care, and the hazard ratio was 0.69. For those patients who are PD-L1 positive, we see that the median survival for avelumab plus best supportive care has not yet been reached versus best supportive care alone, which is 17.4 months, a hazard ratio of 0.56. A similar pattern is seen for those patients when we measure progression-free survival in all patients, it's about a 1.7-month difference in favor of avelumab plus best supportive care. Hazard ratio was 0.62. It's not unexpected that these patients have this discordance with PFS versus OS. We've seen this in other trials where we haven't really hit the PFS endpoint with checkpoint inhibition therapy. We do see an OS benefit overall. So certainly that's something that we need to keep in mind. So what about side effects? Well, we know that the side effects are the typical ones that we see with immune therapy. There don't seem to be any major difference in terms of what we see in patients who are treated in the second-line setting. For all grade 3 adverse events, as one would expect in the avelumab arm, it's 47.4% versus 25.2% in best supportive care. Fatigue, pruritus, urinary tract infections, diarrhea, arthralgias, these all seem to be at a higher rate in those patients who are treated with avelumab versus the best supportive care, but that's not unexpected. These are all manageable side effects, and it's important to discuss this prior to patients being treated. So there's no question that adverse events with patients can be overwhelming, as we see from these particular slides. So Guru, how do you handle that?
Thanks, Dan. So the immune adverse events are clearly an important issue to pay attention to. And as you know, we are still on a learning curve with these adverse events. We were used to a long time with chemotherapy, patients having transient toxicities, reversible and at a certain time point and not really delayed. But now we have to get used to these immune events, which can occur almost at any time and even many months after stopping the immune checkpoint inhibitor. So the principles of managing these adverse events are to educate patients and families about toxicities throughout the treatment, maintain a high suspicion that new symptoms are treatment related, don't self-medicate for diarrhea, don't self-medicate for cough, consult when you have a toxicity with a relevant specialist. You may have a skin rash, you may have diarrhea, and get a gastroenterology consult, a cough, pulmonary consult, endocrine effects, pituitary, adrenal effects may happen in addition to hypothyroidism, which is more commonly seen. Now, if you have immune checkpoint inhibitor related toxicities, you have to know when to continue or when to stop and when to re-challenge, and caution is always advocated. And of course, with the immune checkpoint inhibitors, unlike chemotherapy, we don't really have dose adjustments, right? So if patients have toxicities that are significant enough, it's essentially stop the drug. And in rare cases, you can reinitiate the immune checkpoint inhibitor, but there is not really a dose adjustment. So how do you align management strategy to severity of symptoms? So a grade 1 immune-related adverse event, you could actually continue the agent, monitor the patient closely without having to stop the agent and without having to treat the toxicity with steroids. If you have a grade 2 event, you have to hold the immune checkpoint inhibitor for most grade 2 events. You can resume the agent when the toxicity declines down to grade 1 or less, and you may live without corticosteroids for some of these grade 2 events if they're not too prolonged. For a grade 3 event, you have to hold the immune checkpoint inhibitor and initiate high-dose corticosteroids, 1 to 2 milligrams per kilo per day, or prednisone, methylprednisolone, and taper the steroids over 4 to 6 weeks. It's not a short taper, it's a long taper over about 6 weeks. And one more issue to remember is that if patients don't respond promptly with resolution of the immune event within 48 to 72 hours, you have to start thinking of plan B, which usually includes an agent called infliximab, a TNF-alpha antagonist. If patients have a grade 4 event, that usually warrants permanent discontinuation of the immune checkpoint inhibitor With some exceptions, some endocrinopathies, you might be able to control the endocrinopathy, replace the hormone, and be able to resume. But in most cases, a grade 4 event implies permanently discontinuing the immune checkpoint inhibitor. What's your approach with managing immune adverse events?
So, I mean, I use the stepwise approach that you've outlined. We will try to monitor the low grade toxicity, stop the checkpoint if necessary, add steroids when it's appropriate. The way I like to describe this to our patients is that the side effects that you see with chemotherapy are very, very different than what you would see with immune therapy. With immune therapy, you're going to be seeing side effects that, as you've pointed out, are those of inflammation, diarrhea, thyroid abnormalities, endocrine abnormalities, skin rash, anything that's of an inflammatory nature. Whereas chemotherapy, it's more cytotoxic nature, neutropenia, fatigue, anemia, loss of hair, very, very different. So I try to group them and give the patient a concept. But one of the most important factors in our shared decision-making, as we pointed out, is communication. Making sure the physicians communicate with each other. So if your patient goes into the emergency room with diarrhea, they shouldn't be discharged. They should be evaluated properly. And every time your patient should tell the physician in the emergency room or urgent care center or wherever they may be that your primary oncologist needs to be contacted, because there can be very, very subtle side effects, as we've talked about, that may develop over time. There are things such as diarrhea, which are managed very, very differently in a patient who's on chemotherapy as opposed to a patient who's on immune therapy. So communication is key. Patient education is key, and also having a good support staff of nurse practitioners and specialty nurses that can help the patients triage their symptoms and complaints and also help to manage them.
I agree with that completely, Dan. And another point I wanted to make was of shared decision-making. So in terms of shared decision-making, we have to create a supportive environment for open discussion. I think we have to clarify the timeline needed for the decision, including the opportunity to revisit at subsequent visits and engage the family or others as appropriate. Also, we need to identify decision options and the outcomes affected by those options. Obtain evidence about the outcomes of different options, and also translate the evidence to the individual patient situation. And we need to, of course, check the patient's understanding of everything involved in each option and outcome and provide basic information as needed and be very available to the patient. And I would also say that you need to select the options and outcomes of most relevance to the patient and tailor the treatment to the patient, communicate the expected probabilities of different outcomes for decision options. Engage the patient in a discussion of their values and preferences. Offer advice as the patient requests it to inform the decision, and support the patient in the selection of an option. So Dan, you want to round it up by telling us the SMART goals of therapy.
Thank you, Guru. So let's summarize our discussion with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what I hope that our audience will take from this presentation to apply to your practice. Stay abreast of the evolving evidence in a changing treatment landscape to offer individualized treatment opportunities. Provide patients with the evidence that they need to weigh the different treatment options. Consider patient perspectives and preferences as part of the shared decision-making process. Provide patients with education to empower them to be stakeholders in their care. If you have missed any of the other episodes in the series, I recommend that you check them out. All 3 episodes and a wide variety of education resources for healthcare professionals and patients are available on the CME Outfitters Oncology Education Hub. To collect your credit for today's activity, you can click on the link to complete the evaluation. You'll be able to print your certificate from the platform. As a reminder, if you'd like to apply for ABIM mUC credit, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your mUC points. Thank you, Guru, and thanks to our audience for joining us today.